hold on. Okay.
Great.
All right, so we'll start shortly, but it would be great to just sort of know the background that you guys are coming from, what you already know about F&D, what you're hoping to learn from these 2 sessions. So I'll just sort of start at my end. So Monica, did you want to start? You got a mouthful.
She's got a mouthful.
Oh, that was right. Okay, Kate, you start.
Yeah, I'll
You're
start.
on.
So I'm Kate. I'm a senior social worker from the Campbelltown Camhs team. I've worked in mental health pretty much. That's the only social work field I've actually ever worked in. I guess I'm pretty new to F&D. We started seeing an influx of cases about 12 months ago, coming from the Westmead clinic, or we've just seen a bit of an increase in these presentations. So I've worked on one with Monica as a joint case, and that's probably the extent of my experience. And my role was the family kind of functioning and supporting the parents. And Monica did more of the individual therapy, and we did some family sessions together as well.
Okay.
And it was really interesting, and we both acknowledged that some extra training would be really helpful.
Yeah, awesome, cool.
Yeah, so that's me.
Okay, all right, Monica, did you want to go? Are you on sound, Monica? I'm not sure if you've got.
You can hear me now?
Yes.
Okay. Yeah. So I'm one of the senior psychologists on the Camhs team, and I've worked for Camhs for the last 11, 12 years. And like Kate said, we've seen a real increase in FND cases in the last 12 months. So I've possibly worked with maybe 2 prior to this. And then this year, I've got 2 on my caseload, one of which I was sharing with Kate. And then a few of the clinicians that I supervise have also been taking on some FND cases. So it definitely highlighted the need for training with this increased frequency.
Okay, so Hannah, you're the next on my screen.
Hi there, can you hear me okay?
Yep, good, thanks.
Perfect. So my name's Hannah George, and I'm one of the clinical psychologists at the Community Health Centre. I work at Ingleburn Community Health Centre, so I'm part of the Child and Family Psychology team that operates out of Southwest Sydney. Very new to this area. Sort of my manager passed along the opportunity to do the training, so I'm really excited to hear more about it. As you know, we work closely with ICAMS and things like that. So yeah, it'll be really great. Thanks.
Awesome. Okay, so I've then got Camhs Town. Oh, that'd be Campbelltown. So that's that room with what, 5 people in it or something? Maybe, yeah. Hi. I think they're trying to work out how to turn it off mute. There we are.
Sorry, we got it off.
Awesome.
4 of us in here, we're all from the Camhs team. I'm Teresa, Adora, Amanda and Hess. I'm a bit special because I'm an OT, the other psychs, so need to know about them. I have a similar reason to Kate and Monica, just sort of seeing these cases come through more often and wanting to get a bit more information about how to report. Did you add something? Right. Yeah.
Okay. Alrighty. Okay, Michelle, you're the next on my screen.
Hi, I'm Michelle. I work at Campbelltown ICAMS. I'm the clinical nurse consultant. Been in children's mental health for the last nearly 20 years. Haven't seen a lot of functional neurological disorder patients in my time, but more recently I know that we're getting sort of a bit of an influx in the last 6 to 12 months. So I'd like to know a bit more.
Yeah.
Thank you very much.
Great, thanks. Okay, and Jan, you're next on my screen.
Yeah, hello. Good afternoon now.
I'm not hearing you. I think you're off mute, but I'm not hearing.
Oh, sorry. Unmute.
Yep, that sounds better.
I've got my, okay, sorry. I'm acting team leader in the out of home care whole of family team in Ingleburn, and I'm a previous adult clinician. So I've worked with conversion disorder as an adult clinician. I'm a clinical psychologist, but I want to know more about it in terms of how children and adolescents present.
Okay.
Thank you.
Cool. Great. Thanks. Okay, Naomi, you're next on my screen.
Hi, so I'm a social worker and been with ICAMS for about a year. Yeah, so F&D is really new to me as well, and just looking forward to getting to know about it a bit more. Yeah.
Awesome. Cool. Okay, Michaela. Not sure if she has camera and sound. Her and maybe.
Michaela and Christina can hear, they just can't speak into their computer. So I'll talk on behalf of them. They're a part of Campbelltown ICAMS as well. Christina is a social worker that came on board about 8 weeks ago, so or still new to FND, and Michaela is a psychologist. And Michaela, would you say you're still newer to FND as well? Or? Yeah, she's nodded. Yeah, so all keen to learn more.
Excellent. And then we've got the 25128469.
I don't know who that is.
So maybe someone dialed in.
Yeah.
Okay. All right. So, I mean, mainly we've got mental health teams, I'm gathering. So social work, psychology, we've got nursing. Dee, what's Dee's background?
Yeah. So I'm Dee. I'm the team leader for Macarthur ICAMS. I've got a background in nursing. I'm coming into my 11th year. The last 6 years I've been working in mental health, so both the perinatal infant mental health scene and the Camhs scene as well. I have very little knowledge in FND. We are getting a lot of influx of referrals for kids presenting with FND, and I wanted to be part of this, obviously, just to navigate providing support to the team. I know they're quite complex presentations.
They are, Cool. Okay, and then Sanjay, I'm not going to pronounce that first.
Yeah, this is Vijay. That's Sanjay is my nickname. So I'm the new addition. I've just been here for the last 2 months. I'm a new Camhs clinician. My background is in OT, and they call me as a deputy OT, thanks to.
Okay. All right. So I'm also an OT. So I mean, I'll be presenting a fairly sort of diverse, comprehensive, multidisciplinary team approach to FND because it does require a multidisciplinary team approach. As you've probably seen, the symptoms are quite physical, the neurological, so it does require, your physio, etc. And also the OT input's really important. So today will be more of an introduction to FND, what it is. The second week, which will be next Wednesday, that's going to be more around the management and treatment of it, but you kind of need to know the background to FND to understand people's experience and then how to work with it. So I'm going to go into my slides and share the screen. So then I'll probably lose your guys' pictures. So if you wanted to ask questions, I probably won't be able to see you. So just turn your microphone off and just ask questions as I'm going. Because I won't be able to see you if you're putting your hands up once I share the screen. Oh, 3 people are in the waiting room. Hold on, I've just got to admit some people. Invite. Where's my admit all? So I think I missed them when we're doing the introductions. Can I? Oh, they're joining. Okay. All right. So I think they've just joined. So I'm just going to go into.
So Britt and Nat, they're also ICAMS clinicians. Nat is an Aboriginal mental health worker, and Britt is a psychologist who's had a bit of experience with conversion and FND before.
Awesome. So it now says 17 participants, which includes me. So that's 16 people that's joined. So that'll be everyone, I would imagine.
That makes sense. Yeah.
Okay, awesome. Okay, slideshow.
Can you hear okay? Cool.
Okay, so are you guys seeing my screen?
Yep.
Okay, awesome. All right, so I'll get going. So as I mentioned, I'm occupational therapist, but the president and founder of F&D Australia Support Services. We've been around for a couple of years now and really sort of expanding the services that we offer. I provide OT services. We also offer telehealth counselling. So we have children with F&D that will get counselling through our organisation by telehealth. Okay, oh, Diana, sorry. Okay, thanks, Diana. I've just read your message. Thanks. Okay. Why is this not going down? Okay, so I think we've sort of done our introductions and knowledge. Looks like you're wanting to learn a bit more about F&D. So things that we will cover will be the knowledge of the condition, a bit of the change. I mean, some people mention conversion disorder. So conversion disorder is not used as much anymore in terms of the name. It's still used in the DSM. In the ICD-11, it's changed names again. So most people at the moment are calling it F&D. So I'll be referring to F&D throughout the presentation. But conversion disorder is that old name for this same condition. We'll look at skills to help people manage F&D. And also, because you're a children's services, I've also looked at some specific things that relate to children. And then we'll go into managing the condition next week. Okay, so F&D, as you probably realise if you've worked with people with F&D, it's very complex and it's also very poorly understood. There's been there are a lot of myths out there. There's been very theoretical frameworks that have been proposed over time and frameworks that have come down, across a couple of 100 years. So it is very poorly understood. The research around F&D lags behind other better known conditions. The symptoms are very disabling. So they're presenting as neurological symptoms, so limb weakness, limb paralysis, body paralysis, gait disorder, functional seizures, pain is very common, fatigue is very common. People might have abnormal movements and tremors. Some people have speech problems, some people have swallowing problems, and continence issues are present for some people. One of the challenges is a condition is that the routine medical testing that is done will generally come back normal, but there are some positive signs that are used to specifically diagnose F&D. There is no magic cure or quick fix for F&D at the moment, but the multidisciplinary team and rehab may help. And the outcomes vary. A lot of the research points out that outcomes are poor, but outcomes for children are a lot better than outcomes for adults. And that's possibly because the brain is more neuroplastic as a kid, so they can regain normal movement better than adults can. People who are diagnosed early after symptom onset, they have a positive experience of diagnosis and treatment. Few comorbidities will have better outcomes. Overall, children have better outcomes than adults, but I've worked with a number of children that have been really quite disabled by their symptoms. So I'll be looking at what it is, the prevalence of F&D, a bit of the history of F&D, classification, symptoms, risk factors, and some myths that are associated with F&D. So F&D is now thought to be the outcome of a dysfunction of the nervous system in the absence of structural damage to the nervous system. So it's the disorder in the functioning of the nervous system. We get these disabling motor, sensory, and also cognitive symptoms. And the symptoms, as I mentioned before, paralysis, abnormal movements. But what I didn't mention were also sensory episodes. So we've got people who will be legally blind. Some people lose their hearing. I tend to find the vision disturbances are a bit more common. So FND is an umbrella term, and people are often diagnosed with the type of symptoms that present. So people might be diagnosed with functional seizures, which is also known by a number of different names, which might be dissociative seizures, psychogenic non-epileptic seizures, non-epileptic attack disorder, which tends to be used more in the UK than in Australia. They might be diagnosed with functional limb weakness or paralysis, functional tremors, functional sensory disturbances, or functional speech or swallowing disorders, but they all come under the umbrella of FND. So there have been historically a number of different names for FND, and a lot of these past names impact on stigma and the way that people are treated. So sometimes the seizures are called pseudo seizures. So people don't like that term because pseudo to them implies fake. We've also got non-epileptic seizures, psychogenic seizures, dissociative attacks. At one point, the symptoms were sort of regarded as medically unexplained, but research is helping to explain the symptoms a bit more. Obviously, conversion disorder, which was used in the DSM-4 and is still listed in the DSM-5. FND came about with the DSM-5, and in the ICD-11, they've now termed as dissociative neurological symptom disorder. And there's quite a bit of talk and research around FND being a bit of a dissociative condition, where you sort of got disconnect between the brain and the body. So this sort of relates to people are in a lot of pain, people are suffering a lot, but you often can't see it. So for some people, their symptoms may be invisible, but causing them a lot of pain. And the type of experience that people have had around language is, people see the word pseudo, they freak off, they think, it's fake, they think you're faking a seizure. So the language does make a difference. And when we ask people what are their preferred term, the preferred term is FND, or functional neurological disorder. So looking at some of the research evidence. So FND is very common in neurological practice. It's the second most common reason that people will present to neurology after headache, and it makes up about 1/3 of their presentations to both inpatient and outpatient neurology clinics. And in terms of people being referred to specialist epilepsy clinics, functional seizures make up about 1/4 of those referrals. And in pediatrics, the prevalence is thought to be a bit lower, but it's thought that around 2 to 10% of presentations to pediatric clinics include FND. So we don't have good epidemiology studies, and the studies that have been done were based on the DSM-4, not recent studies, and the DSM-5 has removed the criteria for a psychological trigger. So the DSM-5 has opened up the number of people who can be diagnosed with FND. So the studies that are out there will be very underestimated. So some conservative studies suggest that the rates could be 12 to 50 per 100,000. But in our support network, we have around 2,000 patients just connected in our online support group. So I would say that this is quite underestimated. In children, it's thought to be around 4.3 per 100,000, and children as young as 6 to 10 are being diagnosed. FND is a lot more commonly diagnosed in females than males, and at a rate at about 3 times that of males. And in our support group, we tend to see about 80 to 90% females, which again may be biased in terms of females might be more likely to reach out for help, but we've definitely got a greater percentage of females with FND. So in terms of prevalence, in comparison to MS, FND is more common than MS. So in this study, this is a study in Scotland, FND made up around 16% of referral to outpatients neurology, whereas MS made up 6%. FND had an equivalent level of disability to neurology, but in terms of neurologist popularity, it was 5% of neurologists were happy to see people with FND, and 90% of neurologists were happy to see people with MS. And in terms of public understanding at that point in time, around 2013, it was 2% of the public had heard of FND and 95% had heard of MS. So these two things really impact on patient care, patient experience, both in the medical setting and also in the community. So historically, FND has been classified as a mental illness based on theoretical models. So Freud proposed that people were subconsciously converting stress, trauma, and internal conflict into a physical response. There is now new research that has looked at FND and what's going on in the brain, and looking at the functional connectivities between what's happening in the brain, which sort of starts to challenge some of this. The current DSM-5 is based on one or more symptoms of altered voluntary motor or sensory function, and this is referring to voluntary pathways, not in terms of people are putting it on, as opposed to autonomic things like keeping your heart pumping. The DSM-5 refers to there's evidence of incompatibility between symptoms and other recognised neurological or medical conditions. The symptom is not better explained by another medical or mental health condition, and that the symptoms causes clinically significant distress and impairment in social and occupational functionings. You then might specify the type of symptom. So is it weakness and paralysis, abnormal movement, speech, swallowing, your seizures, sensory loss, or mixed? And it's specified as in, is it an acute episode or is it persistent? So this actual classification is important if you need to start looking at the NDIS. So NDIS, you have to have a permanent disability. So we don't like to think that people, some people can come down with just an acute episode of FND and recover well, especially children. But for other people, they will go on and have years and years or lifelong symptoms of FND. And now the psychological stressor has just become, is it with a psychological stressor or without a psychological stressor? And this was originally a diagnostic criteria. So that's now been removed in the DSM-5 so that people without any psychological stressors or history can get a diagnosis of FND. Okay. So one of the problems around FND is that people are really slipping through system gaps between the mind and the brain. So is it neurology? Is it psychiatry? And it's talking about FND really lacks this disciplinary home in medicine. People, neurology might refer people to mental health. It's classified under the DSM. You must have a mental health condition. And then typically mental health might say, well, you're presenting with physical symptoms, you're paralyzed, you can't walk, you're having seizures. This is outside my realm of mental health. So people feel caught between this gap between neurology and psychiatry. My neurologist tells me I'm dealing with something psychological. My psychologist tell me it's organic. So people do struggle, and also health professionals struggle. So we really need the professions to come together and work collaboratively in this condition. So in terms of describing FND, how we often describe it is a software malfunction. So in FND, by definition, there is no damage to the brain and the spinal cord. So there's no damage to the nervous system. And you can have damage to the nervous system as well. But with FND, the problem is the way the nervous system functions, not damage to the nervous system. So because of this, there is that potential for recovery, which you may not have in, say, like a spinal cord injury or a brain injury, because it's just a software malfunction rather than a hardware malfunction. Other descriptions that may be more receptive to children is looking at a phone analogy. So you can have a mobile phone that's fine, it's not damaged, there's no cracks on the screen, but you can't hear, you know, it's crackling up, you're missing words, you can't hear what's happening. So just like the signals are interrupted on a phone, this is like what's happening in the nervous system. So the brain and the spinal cord are okay, that hardware is okay, but it's a problem with this communication. So it's not communicating properly, which is why there are mixed messages. That's this one. Another analogy that was used for a young child when that didn't work is like, if you take a ball of string, the string on its own is okay, but when it's tangled, it doesn't work. So you can't do what you need to do. So this is a bit like FND. The actual hardware is okay, but it's all tangled up and it's not working properly. So in the normal situation with our FND, normal neurological functioning, the brain will communicate with the body and the body will communicate with the brain. But what happens with FND is, in the presence of an intact nervous system, we've got problems with the functioning of and communication of messages between the brain and the body, and that can result in motor symptoms. And we can also have problems with how the body communicates with the brain, and that can result in sensory problems. And we can have both of these problems happening at the same time as well. So in terms of FND symptoms, we'll start on the seizures, which are very disabling, and they're different to epileptic seizures. So sometimes these seizures might be called non-epileptic seizures, dissociative psychogenic functional pseudo-seizures, so all referring to the same symptom. So they are very serious, they're disabling, and they're frightening. So they can be frightening for onlookers to see, for family members to witness. It may look similar to epilepsy, or it may look more like a drop attack, like someone's just fainted. People can have these shaking experiences, excessive movements, or they simply like drop to the ground and just like black out. We tend to find that when people are having a seizure, they're not able to respond. So if you're talking to them, they're non-responsive, but they can actually hear what's going on around them, but they're not able to communicate. So it's also highly distressing to the people experiencing the seizures. And contrary to some of the myths and the literature, there is a risk of injury. We have aware of people who have died having seizures. So, you know, someone drowned in a bath, another person aspirated, they just had breakfast and they aspirated on that and they died. Lots of people will break bones, they have bruises, etc. when they fall. So they're still just as serious as epilepsy. But unlike epilepsy, it's not due to changes in the electrical activity of the brain. So that means that the normal epilepsy medication will not work with a person having a functional seizure unless they also have epilepsy and it's actually an epileptic seizure. So the way that this is tested is through a video EEG. And if it's a functional seizure, it'll come back normal. Some people will have epilepsy as well as functional seizures, and it's actually quite common for people with epilepsy to also have functional seizures. So it's thought that the driving force behind the seizures is dissociation, which is why some people call them dissociative seizures or dissociated attacks. The seizures often occur in response to environmental stimuli. So people might say, you know, noise can set off a seizure. It could be stress. It could be temperature. Some people say that if it's too hot, they'll have a seizure. Movement. Someone said, you know, my daughter dropped something and that movement, my vision of this item dropping to the ground set off a seizure. People may have a feeling of sort of depersonalization or out of body experience beforehand. We may get these altered movements that look like epileptic seizures and the appearance of loss of responsiveness. So these are how different seizures can present. So here we have just like the shaking, we have tearing, the eyes are closed, And this also went on for a long time. I think this went on for a few hours. And she was just lying in bed like that with the little jerks. Sometimes you can get the rolling one, so either head side to side or body side to side. And again, this one went on for a number of hours. There's another one. Head shaking. And there's a bit of grunting there. I'm not sure if you can hear it. And what I noticed there is when her husband came up and gave her a hug and sort of soothed her and held her, her seizure started to resolve. So things, sensory input, dogs, gentle stroking, gentle touch can help for some people. This is a young girl who's dealing with FND at the moment, and she has the most violent seizures, broken bones, she's damaged walls. Her mum's been injured in the seizures, really, really quite violent. It says here she's kicked holes in the walls, she's fallen off the bed, she's had seizures in the bath, she's kicked the shower screen as she fell off her bath board. A number of people will have seizures in the bathroom. I've had someone that says the water on their back can set off a seizure, and the temperature of the water can set off a seizure as well. So it can be really hard to manage. And this says, you know, this teenage girl has no independence and can't even shower alone because it sets off these seizures. So in terms of managing these, don't ignore the person. It's like comforting and reassuring the person. You want to reduce that anxiety. You want to reduce that arousal, help them feel calm, help them feel safe, ensuring that they do not hurt themselves. I think going back in time, they used to say, just ignore the seizures and then they'll stop. That doesn't work. It tends to be when the person feels safe that the seizure can start, they come down and they start to stop the seizure. There was one occasion in our cohort, this young girl in her 20s, she fell to the ground and they thought she was having a seizure. And the family just said to the people who are around, or just ignore her, don't give her any attention. And we were told she'll just stop. But the friend who was around at the house was actually a nurse. And so she checked on this person and found that she had a weak pulse. And what was actually happening was she'd fallen to the ground because she was having a heart attack. So we do need to take this seriously. This person was okay. She had the heart attack treated, but it's just a reminder that it may not always be a functional condition. People with functional conditions can also have heart attacks and stroke and any other type of medical condition as well. So functional seizures are not assisted by anti-epileptic medication because the cause is not due to changes in the electrical activity of the brain. So giving people these medications will not work. So in terms of motor disorders, this can present as limb weakness, paralysis or limb paralysis, gait disorder, your abnormal movements, dystonia can be quite common, and also dysphagia. And it may look like a stroke. People are often affected more on one side than another side. So a number of people are incorrectly diagnosed as a stroke initially because it can present like a stroke. People have also been diagnosed with MS as well when it wasn't. It's another young girl having motor problems, just a sort of wriggling of the legs. And then dystonia, so people can have these locked positions and not be able to move their foot or their hand. So this can make it really difficult to walk if you've got dystonia of the feet. So some people will end up in a wheelchair because of feet dystonia. And obviously this in the hands impacts on your fine motor activities as well. And these are your gait disorder. So this abnormal control of movement.
Go. Indeed.
And similar for a young person. And then the body can feel like lead, just trying to move. So walking becomes really challenging. People need to sort of think about each step. It's not an automatic process. And part of the goal of rehabilitation is to help walking and movement become automatic and to get back into those normal neural pathways. So here we've also got curled toes. So your toes are cramped over. And then we've got it in the hand with the dystonia in the hand where people can't open the hands. It's all locked up. So that then obviously impacts on all your fine motor activities when your hand's locked up like that.
Guys, this is what I'm dealing with at the moment. This really is hard to keep my mouth up. It was unilateral for about a day yesterday, all on the right side, and now it's both sides. I have no idea what's going on. Seeing my GP later today, and yeah.
So just as people can be affected in the legs, they can be affected in the face, which impacts speech, and also how the face is controlled. And then we've got these abnormal movements in facial muscles. So I have some clients where this can be a periodic thing. So it might come and go. They might have periods where they can't talk and then periods where their speech is normal. And then I have other clients who've completely lost the ability to speak, haven't spoken for years, and they communicate by a whiteboard. And that's sort of one of the things about FND is your symptoms can fluctuate quite wildly and have periods of normality and then periods where it's really, really severe, or people may have these constant symptoms. This is a speech disorder one, and this is one that comes and goes.
Okay, the date is 21st of July, 2020. Shelley's hasn't had a seizure, but she's lost her voice completely. She can't talk. Only way of communicating is through text-to-speech. This is Shelley now. So, have you lost your speech, baby? You can't talk? No talking. Gone? That's gone, yeah. So Shelley can't talk at the moment, so she lost her speech completely. And this is basically a daily thing on what she's going through. So communication is very hard. And it's all text to speech that how she communicates. This is just for the records.
A number of people will say that a seizure sets off their symptoms. So they're saying they haven't had a seizure, but often a seizure, people might come out of a seizure and they might be paralysed, or they might not be able to speak, or they might have lost their vision. So a seizure, they might have a seizure for a few hours, and then they might have a few days where they can't speak, they can't move, and then their symptoms might resolve and then it will start again. So this thing with speech issues, people will be seeing a speech therapist, and they may require various augmented communication devices. In our counselling services, we've used telehealth, so people have had to have their counselling sessions using the chat function on Zoom and communicate with the therapist that way because they weren't able to speak. This is another one with a speech disorder.
But also when the speech is like this, for anyone suffering FND and have speech difficulties, because sufferers were all different. Some have gait disturbance, some have a whole bunch of stuff. There's hundreds of different symptoms. But my case for the speech, if I change my tonality or pitch, or if I put on an accent, it will distract my brain pathways and connect to ones that are working, and I am able to talk without difficulty. So I just have to change slightly my speech and I'm able to talk. It might sound really funny for those of you that know how I actually speak normally, but this is how the brain works. And if I have an episode of standing still, I continue to sway backward, and when I walk to the left, so my gait is disordered. So that's called astasia abasia. And if I distract myself or talk, use my hand, think about something else, I'm distracting certain parts of the brain, and I'm able to walk, and I'm able not to fall back when standing. But then if I go back into my normal speech pathways, they are obviously affected, and yeah, I kind of struggle. So if you need teaching.
So she's talking about distraction there, and that's something that's used in treatment, and I'll go further into it next week. But it's if people are doing something different and they're using different neural pathways, some of the normal movement and the normal speech might come back. The other thing that hasn't been mentioned is some people with the speech problems also end up with foreign accent syndrome. That sometimes comes up as well with people with FND. And the other problem is functional cognition disorders. And this is also something that tends to come up quite a lot, and is obviously very hard for people who are studying, kids at school, people at university. Some people lose their memory. They might have their long-term memory that might stay intact, but their short-term memory might go. We've got some people, some children with such severe memory issues that they can't remember their family, they can't remember where they live. If they go out and then they have sort of an episode, they don't remember how to get home. So that has caused a lot of issues for some families with young children with memory problems. People often lose attention, they lose focus, they have problems with auditory processing, visual processing, they just can't focus at school. So this is also another problem that comes up quite a bit. People can't, thinking about OT, sequencing, planning, all that sort of stuff might go out the window for some people. So then looking at who gets FND, there's no underlying definitive cause. There are a number of risk factors. So you'll probably find, being a mental health service, that people with FND, there may be a pre-existing mental health condition, there may be emotional trauma, there may be a lot of emotional stressors, bullying at school, etc. But some people will get FND having had no pre-existing mental health condition. They may have had a pre-existing physical health condition, so they may have another neurological condition, they may have medical conditions, they may have had a number of surgeries. Surgery can be a trigger for a number of people, and for some people an accident or an injury might set off their FND. Long-term stress is quite common. People would sort of develop FND in the background of long-term stress, but for some people there will be no identifiable trigger. I have a lot of people that say, oh, there's nothing in my background, and when you talk to them you find that there is. But some people say, especially with children, there was absolutely nothing that set this off. But for most people, I find there will be something in their background that set off the FND, or that was a risk factor for them developing FND. For many people, it's often a number of factors that will set off FND. So they might have a physical health condition that weakens their body. They might have a lot of emotional stress. It might have been triggered by surgery or an accident. So it's really just a number of risk factors that can potentially overwhelm the nervous system, and the outcome is dysfunction of the nervous system. So predisposing risk factors, female, younger age. So, like we think of sort of stroke, MS, Parkinson's as being older people. We've got very young people, children, adolescents, people in their 20s and 30s coming down with these really disabling conditions. There may be this coexistence of physical health, emotional health, personality disorders, often interpersonal relationships, difficulty, problems, stressful life events. What is common is sort of the perfectionism, people that push their body, so dancing, sporting activities, perfectionistic traits at school. For older people, carer burden, there might be people that have a number of kids with autism and they're under a lot of stress. Adverse childhood experiences. The studies show that people with FND have a greater number of adverse childhood experiences compared to healthy controls. And it's thought that there's a genetic vulnerability. There's limited research around this, but there's recently been one genetic paper that's come out. And what we see through the groups is FND may run in families, which could be environmental, but it could also be genetic as well. And the other common comorbidity that we often see is this hypermobility. So people that have Ehlers-Danlos syndrome also have or can have FND as well. So stressors in children that seems to be common who've developed FND are often school-related difficulties. So really pushing themselves at school, bullying at school, potentially family conflict. So sort of stressors around family breakup, your interpersonal conflict, so cyberbullying, peer problems, changes in the home environment, distress and others, so parents being ill, witness, so there was one kid that I knew of, witnessed her father being murdered, physical injury, and tends to be more the kids who will internalize their symptoms rather than talk about it. So a number of predisposing factors were thought to be a genetic vulnerability, which may be triggered by environmental factors. So this genetic paper has looked at the impact of particular genes, and it has found that for a particular gene, if you have one allele, it makes you have much greater FND symptoms, and your FND symptoms correlate with childhood trauma. Whereas if you were GG, so I don't know if you've all done, your DNA stuff, but with a type GG, people who had childhood trauma, there was no increase in FND severity with childhood trauma. If you were a T carrier, childhood trauma increased your FND severity. And it was also shown that this changed the brain connectivity. So people with this allele had greater connectivity between the amygdala and the right part of the brain, the middle frontal gyrus, which then increased the connectivity between your emotional part of the brain and your motor part of the brain. So there may be risk factors for FND, but just because a person has FND doesn't mean that that risk factor is present. A lot of people are quizzed and told you must have had childhood trauma, you must have been sexually abused, and that's why you have FND. Some people have been told, oh, you had childhood trauma, but your childhood trauma was so severe that you don't remember it, and your body is expressing your childhood trauma through developing these symptoms, and that can be quite traumatic for a person to hear, especially if it may not be true. So psychological trauma will be relevant for some people, but it's really the sole explanation, in the same way that smoking may trigger stroke. It may be associated with the development of stroke, but plenty of people have stroke without having ever smoked. So in the same way, some people who experience FND have never had any psychological trauma. But overall, we do tend to find that a greater number of people will have comorbid psychiatric issues compared to the general population, but not everyone. A number of people will say that they have psychiatric issues. They will relate to that. They will relate to stress, but about 1/3 of patients will say there is no psychological trauma and there is no stress. And the research showed that people with FND did have significantly greater what they called escape events, so adverse experiences that they wanted to escape from. So that could be they were saying, oh, people came down with FND because they didn't want to do an exam, or there was a theory that went back to World War II, and it was regarded that people came down with FND to get medically discharged from the army. So that pilots all of a sudden developed these vision problems, these functional vision problems. So then they were medically discharged from the army. But obviously working in the war and working in the army would have created a lot of stress on that body. So there are many factors that can contribute to FND, but they're going to be different for different people. There's also many different symptoms that people can develop. So this just highlights the need for holistic and individual care. What might be relevant and important to one person may not be relevant and important to another person. So things that tend to precipitate FND is something physical. So we often find there may be a background of stress and trauma and various difficulties, but it's often something that will set it off, and it will often be something more minor. So for example, just a fall to the ground or a fall down the stairs where there wasn't any major damage, but this was something that set off FND. Some people have spoken about accidents, like a car accident, where the effect of the car accident wouldn't have been enough to produce the disabling symptoms that came about. Some people describe an adverse reaction to a vaccine or an adverse reaction to a medication, or they went into surgery and came out with FND. So just like there are many ways to break a bone, the outcome is a broken bone, and we've got to address the broken bone. In the same way, there are many reasons why people develop FND. So we need to focus on the outcome is this dysregulated nervous system with motor, sensory and other neurological symptoms. So we need to address what's going wrong for that person and focus on helping that person address those symptoms. So just looking at some myths that are out there around FND. So there is this myth that all people with FND have psychiatric illness. And what we tend to find is that living with FND can cause psychiatric illness. So with the result of the grief and the loss, all the things that they can't do, the change on their life, managing these daily symptoms. For a lot of people, it would be hard to live with FND without also developing anxiety and depression and grief and loss. So for many people, FND is a cause of mental health problems. So there is this myth out there that FND is the result of a repressed and subconscious trauma that people can't remember. So we know that trauma is very prevalent in the general population. Some people with FND will obviously have trauma and adverse experiences, but not everyone. And most of the people who have had trauma will remember the trauma. It won't be this repressed and subconscious trauma. Many people, because it's in the DSM-5, people are told, you just need to see a psychiatrist and a psychologist and you'll get better. You just need to do some CBT. And because of the nature of FND, generally psychological and psychiatric treatment is not enough. People require that multidisciplinary care. Psychology alone is not likely to cure FND, but it can be very helpful and also really important as part of people's recovery journey. There's also this myth that people just need to accept the diagnosis, go home, and then they'll get better. So accepting the diagnosis on its own does not lead to recovery, but it is important that people accept the diagnosis as part of the process of working towards recovery. So there will be some people and some families that will reject FND as a diagnosis, and they will keep looking for another explanation. And because it is in the DSM-5, so classified under mental health, a lot of people will say, I don't have any mental health conditions, this is not me, it must be the wrong diagnosis. And not accepting the diagnosis can obviously delay treatment and delay the right treatment. It's assumed that people either have a neurological disease or they have FND. And in fact, it's actually more common for people to have both. So if you already have a neurological disease, or even things like cerebral palsy, epilepsy, autism, it's more likely that people will have a functional overlay. So they'll have FND in addition to a neurological disease. So in the same way, people with FND can also develop other neurological conditions, for example, MS and epilepsy. And there is some research in Parkinson's that suggests that around 30% of people who develop Parkinson's were first diagnosed with FND. So it may even be a prodromal illness in some cases. So people with FND can and do develop other neurological diseases. So that means that new symptoms, different symptoms, symptoms that change over time need to be reviewed and followed up. There's a very common belief that comes down through the sort of secondary gain theories that people with FND are malingering, they're attention seeking. A lot of children have been accused in the past of putting this on because they're seeking attention from their families, or else they're trying to avoid school. For some people, they've got confused around the F and they've called FND fictitious neurological disorder, which it is not. And sometimes some parents have been accused of Munchausen by proxy. So people with FND, they're not malingering. They're often people that are the ones who push themselves too far and they're not attention seeking. And things like factitious disorder and Munchausen syndromes are completely different diagnoses. So FND is a genuine medical condition and the symptoms are not volitional, they're involuntary symptoms and the people are not in control of their symptoms. Some people have this belief that, you know, it's a really complex illness and there's nothing that we can, or there's nothing wrong with people. This one is, there's nothing wrong with people with FND. So they've done the scans, they've done your blood test, there's nothing wrong with you. Go home, no intervention is required, when in fact it's actually the opposite. It is a very serious, complex and disabling illness. It impacts across all areas of life, and intervention is really important to give people the best chance of recovery and to support people to self-manage the illness. And just because we can't see it on a scan doesn't mean that there's nothing wrong. This one is, once people have an FND diagnosis, all new symptoms must be related to FND, so we don't need to investigate them. So if people develop a different symptom, it does need to be followed up. And there's been a number of situations where people have basically done their own diagnostic overshadowing. They've developed new conditions that are quite serious and they've just said to themselves, oh, if I go to a hospital, they won't believe me. So it's probably just my FND, and they've let it go. And that thing might have been something that was potentially treatable. For For example, even like a vitamin deficiency can lead to different symptoms, and when they have that vitamin deficiency detected and addressed, a whole lot of symptoms resolved, and that has come about with a number of people. So any new symptoms do need to be investigated and taken seriously. Sometimes people just say, oh, F&D is just anxiety or a panic attack. So anxiety and panic attacks will make people worse, but it's not just anxiety. And because anxiety and panic does make symptoms worse, things like grounding and breathing can be really important in helping people manage the symptoms, but it's not necessarily a cure for FND. Is that a question coming in there, or is that just someone entering? Okay, so the other myth is around the secondary gain function of FND, and that's been documented in the literature historically for a couple of hundred years. And that ends up being quite insulting to patients and their families. And people describe the experiences of major losses, not gains. But often people are accused of this secondary gain. Oh, you're putting this on because you don't want to go to school, or you're putting this on because you don't want to do an exam. But overall, people with FND experience major and significant losses across multiple areas of life. And many people will say, I've lost my job, I've lost my career, I've lost my identity, I've lost so much. There's no secondary gain at all. The other myth is around, they can't be serious because your symptoms fluctuate rapidly. And so obviously the symptoms are not real. And it is true that FND symptoms do fluctuate rapidly. So, you might have people who are paralysed at one point in the day, so paralysed in the morning, but by the afternoon they're feeling better and they're running around. Or we've had, someone who, a child went to school during the day and her mum dropped her off at school and she was walking and going really well. She started to get tired during the day and then she couldn't walk. So she spent half the day in the wheelchair, and then she was feeling a bit better and was able to walk. So the symptoms do fluctuate quite rapidly. So people might be able to do one thing on one day and not on another day. So this is because it's due to the functioning of the nervous system, not damage. So because it's due to problems in the functioning of the nervous system, the symptoms will fluctuate based on environmental triggers, based on fatigue, dehydration, pain, the various health status. So people will say they're a lot worse if they've got flu, they're worse if they've got stress. So symptoms can vary across the course of the day and on different days. The other myth is around disability aids medical interventions. So a number of people say that, we can't give you a wheelchair or we can't give you crutches because it'll feed the disability. So at some point, disability aids may be relevant. You don't jump to disability aids when someone first comes down with FND. You obviously want to do your rehabilitation, see if you can get the person walking, or you may have to use it at certain times, but not other times. The other big one is around for adults, the DSP. People say if you go on the DSP, you're just going to be disabled. And medical intervention. So if we give attention to this, we've got someone that can't swallow, so she goes into hospital, they have a tube, take the tube out, go home, can't swallow. So they have tried to, in that situation, they tried to avoid using the tube because they said it would just feed the problem. But she basically just got to the point where she nearly died because they delayed medical intervention and her body just got so ill because she couldn't swallow. So at times, people will require medical intervention and they will require disability aids. But given the symptoms do fluctuate so rapidly, the intervention and the adaptations, the aids, they need to be continually reviewed and to make sure that it's the right aid or whatever for that level of disability. For people with chronic FND, so if it sort of ends up being, you know, a lifelong condition, the disability aids may be required to have a quality of life and engage in meaningful activities. But if the symptoms are fluctuating, you know, they do need to be continually reviewed, and also making sure that it's the right aid at that point in time. So using it when you need it, not using it when you don't need it. There is a myth, and it is in some papers, that people with FND are not injured by their symptoms, but in reality they are. And a number of people have experienced significant injuries during seizures and through falls. We've got a number of people who have had really severe concussion and head injuries due to falling in the bathroom. And people have died having functional seizures. So the symptoms are serious. And then there's this myth around FND being voluntary. So by definition, it's a problem in the voluntary motor pathways, but that is different. That's a reflection of I choose to walk from A to B and my muscles do what I tell them to do, as opposed to the autonomic nervous system, for example, what controls our heart rate and our blood pressure. So FND symptoms are involuntary, they're not put on. And research has shown that there is dysfunction in brain regions involving movement, planning, attention, body monitoring, and sense of agency. And brain scans have also shown differences between people with FND and those faking symptoms. Is there a message? Hi, Kate. I think Dee.
Yeah, no, that's me. It's Dee.
Yep.
I'm just wondering, a lot of our consumers are financially disadvantaged. So when we talk about medical aids and equipment, is there a subsidised scheme for consumers who are diagnosed with FND?
Well, this is the issue that we have, because there's the NDIS, but obviously with the NDIS, you have to have a permanent disability. And especially with young kids who have just had an onset of this condition, you don't want to diagnose the permanent disability. And obviously in the first 6 months, you can't. So that sort of ends up being a problem. And also for people to access, if they've got financial challenges, they can't afford the psychology, the physio, the OT, the intensive rehabilitation that they need. But if they get onto the NDIS, it's covered through the NDIS. So that's one of the barriers that we do see. That's
the big issue I've had, Kate, is I've done one NDIS application now, and I feel like the NDIS themselves weren't really educated on it, and I was having this huge issue to try and get this kid some funding. And the reports they were asking for me were quite difficult, because they were asking for me to provide reports from a currently involved neurologist. However, the neurologist is saying I'm not involved, it's now the psychiatrist. And it was this and literally I've just been unsuccessful. So I don't know if there are any tips or
so with NDIS, I do these every day. So I've written a letter which people submit to the NDIS, and I'll provide that in the package that I send through. So people are using this letter when they're applying for NDIS and DSP. So it describes the condition. It talks a little around the research around permanency and what the condition is. I do a lot of these NDIS applications. So I do a number of those, functional capacity assessments. I do, the assessment tools like the HUDAS, the CANS, the lower extremity functional scale. And then I reference the literature around the permanence of the condition. I do cover in the session next week, I've got a little bit of information about the NDIS, which I'll cover next week. But I'll definitely give you that letter if you want to use it. And the other thing that I'm doing is I see people as an OT and write these reports for NDIS, but I also have OT students with me, and I've got them currently. I've got 3 OT students. So I've got the students, I've trained them up to write these reports for NDIS. So they're providing, they're seeing people applying to the NDIS and documenting these reports. And so people are able to get that at a really low cost because they're students on placement, as opposed to if they're going to see me or get, an OT to write a report. So it's something that we do every day, and it's around supporting people getting NDIS, and then also trying to educate NDIS planners. And obviously, you know, the paperwork goes to different planners every single time. So it is around educating the planner, and they'll often follow up, you know, with me for further information and clarification. And the big issue with NDIS is also because the symptoms fluctuate rapidly. So, you know, on one day, people might be walking and running, and the next day they might need a wheelchair. So that's really hard for NDIS to understand how symptoms fluctuate rapidly.
Sorry, this is Vijay here. Sorry to interrupt. Can you hear me?
Yeah. Yep.
In regards to NDIS application, would this comes under a psychosocial disability category?
No, because the symptoms are physical, and often people require, you know, wheelchairs, home modifications. I mean, I'm working at the quite, you know, high level of disability end. So the people that I'm working with, because their symptoms are physical and they do require, you know, expensive wheelchairs and expensive home modifications, it goes through more under physical and neurological. Because psychosocial, it wouldn't cover the mobility challenges that people have, the equipment that they need.
Yeah, no, thanks.
Often though, I'll report like it's very common that people will have a psychosocial disability as well. So if there's underlying trauma and PTSD and anxiety and depression, I'll report on that. But the primary disability will be FND, often with a comorbid psychosocial disability.
Thank you.
Okay. There's this other myth around there's nothing we can do. So people are given a diagnosis, they're sent home, they may be given a website and told, "I'll just read about it." So when left untreated, the prognosis is unfavourable and people generally don't get better. So people do require individualised treatment from a multidisciplinary team, and that multidisciplinary team will depend on what the symptoms are. So for some people, speech and dietetics might be really relevant, and for other people it won't. If there's gait problems and movement problems, a physio is relevant. If there's not gait problems, then physio might not be relevant. Because the condition is regarded as potentially reversible, people can learn to self-manage the symptoms. And that's a lot of the treatment that we look at, is around how do we self-manage the symptoms? How do we help people to reduce the nervous system arousal, to ground, to reduce their stress levels? People do need to feel supported, heard and validated. And often people have had these adverse experiences in the health professions where they're told there's nothing wrong, you're putting this on, and that invalidation can lead to worsening symptoms. If there are comorbid physical and mental health conditions, they also impact on outcomes quite significantly, and they need to be addressed as well. So for some people, there's a myth of the prognosis of FND is good, just accept your diagnosis and go home, when in reality, the prognosis overall is quite poor, although children do have better outcomes than adults. So I know in that Westmead program, I think they talk about 60% of children have improvement, but there are still some kids that don't, and kids that can be really, really disabled by their FND. In terms of the research, it's found that people with FND are just as disabled and have as impaired quality of life as people with other neurological diseases such as Parkinson's, MS and epilepsy. And when left untreated, prognosis is unfavourable for most people. How are we going? I'm just going to cover a bit of what's happening in some of the research around the brain imaging studies. So when they do functional MRIs, they will find quite significant differences between people with FND and healthy controls. And they're saying that FND is a disorder of connectivity in different pathways in the brain. And the areas implicated tend to be the motor parts of the brain, and also your limbic part of the brain, so the amygdala, and areas of the brain involved in emotional processing, self-agency, awareness, attention, and cognitive control. And one of the big things that we note in FND is this aberrant connectivity between the amygdala and the motor area of the brain. So this means that people with FND who have an emotional reaction, so they might get stressed, they might get a shock, an emotional shock, that can then set off these motor pathways. Now, this is an aberrant connectivity. So healthy controls don't have this connectivity. So healthy people without FND, they can get upset, they can have something emotionally bad happen to them, they can experience trauma, and it doesn't cause them to become paralyzed or have a seizure. What they've also shown in the functional MRIs is that people's symptoms relate to what they see in the brain. So they found that people who have motor symptoms have an underactivation of their motor cortex, but people who have vision disturbances have an underactivation in the visual cortex. So they can identify what is actually going wrong in the brain. And they found that people with FND tend to have overactivation of the amygdala and the emotional centers of their brain. And in the research setting, they're also finding structural abnormalities, but these are not structural abnormalities that you would see if you send a person off for a structural MRI. This is when they compare the brain volume of children with FND compared to the brain volume of healthy controls. And what they're finding is that there's increased volume in parts of the brain with FND and decreased volume in other areas of the brain. And it's not yet known if that's causative of FND or the result of FND. So due to the changes that are associated in the brain when the person has ongoing FND. And again, the areas that are involved are the areas that involved in the perception of emotion and modulation of the motor responses. And this study shows a similar study, but this one is in adults, and the same type of thing, that there's abnormalities and grey matter volume in areas involved in the limbic part of the brain, so your emotional part of the brain, and the motor circuitry. And these are in patients with functional movement disorders. So they find increased volume in the amygdala. So the amygdala is really overactive, and decreased volume in the sensory motor cortex, which is why people don't have their normal control over the motor movements. They've also found that areas of the brain that are involved in self-agency, so if you sort of say, I want to walk over there, and you can walk over there. So there's decreased connectivity in areas involved in the right temporal parietal junction, which is how you feel yourself, self-agency, and the sensory motor regions of the brain. So the right temporal parietal junction acts as this mismatch detector between motor intentions and motor consequences. So if you intend to walk from A to B, normally you can do that, but in people with FND, these parts of the brain are not talking together. So there's dysfunction in sensory motor integration with hypoactivation of the right temporal parietal region, which results in this loss of agency. And they say this validates the patient's experience that FND symptoms are involuntary. So is recovery possible? If people don't get treatment, the outcomes tend to be pretty poor, but we talk about them being potentially reversible because there is no damage to the nervous system. And especially in young people, while their brain is neuroplastic, if people get the right treatment early on, there can be good outcomes in young people especially. But we tend to find that they're neglected, and the research on prognosis that is in the literature highlights really bad prognosis in adults, but I think that also does relate to the fact that people haven't been getting the treatment that they need. So the prognosis overall that's reported, and this is adults, is poor, So 50 to 90% of people with FND experience ongoing symptoms, many of which become worse if treatment begins later than 6 to 12 months. So you really want to get in early with the intensive treatment as soon as people have symptom onset. And one of the challenges around diagnosis is if people are diagnosed late. I mean, I've had people find us and they said, look, they've had these symptoms for 20 years before they got the diagnosis. By that stage, your brain is sort of locked in these abnormal pathways. So you really want to sort of address the brain function and the rehabilitation in these early stages. More recent studies have found that at a 12-year follow-up, the majority of patients remain symptomatic, distressed and disabled, and the long-term disability was similar to people with MS. So the more favourable prognosis is acute onset, so a clear precipitator that led to symptoms, and then when that stressor has hopefully been resolved, people have increased rate of recovery. The younger age, so the presence of an identifiable precipitating event at the onset of symptoms, previous good health and not having any other comorbidities, mental health or physical health, having a quick and clear diagnosis and with an explanation that is acceptable to the person. So if the person doesn't accept the explanation, if the family doesn't accept the explanation, if they're looking for something else, that impacts on treatment and recovery. And obviously the availability of F&D informed treatment. So the poorer prognosis, the longer people have had it, the worse the outcome. People who don't fully recover, people who have repeated episodes, if a person just had an onset of a condition, they got treatment, they improved, the longer they go without having any relapses, the more favourable the prognosis. Negative interactions with medical staff, so not being believed, experiencing derogatory comments, the failure to make a quick diagnosis and the failure to offer appropriate treatment, and also providing the wrong treatment. So treating a person with functional seizures with epilepsy drugs, all those type of things will impact on patient recovery. I've done that one. So are there any questions that have come up that you wanted to address? We've got about 5 minutes, or I can start this.
Hi.
I've got a question. Oh.
Hello.
I've got a question, Kate.
Yep.
So you mentioned imaging studies.
Yep.
So apart from imaging studies, what other kind of assessment tools would be useful for diagnosing or treating FND? You mentioned that like the slightest noise can trigger a seizure. Would functional assessments and sensory profiles be helpful for that? Yeah,
absolutely. So that's sort of what I'll cover next week.
Okay.
So there are various positive signs that are used for diagnosis. So obviously there's no scan, there's no blood test, there's no indicator like that at the moment, but there's positive signs that will indicate that this is potentially FND, that's what we're dealing with. And the thing that I tend to find is I do those sensory profiles, and every one I have done, people have come up with, you know, the third standard deviation with, you know, extreme deviations from the norm. So whether or not that's sort of like as a result of FND or a cause of FND, the sensory processing issues tend to be really, really common. And so sensory modulation interventions are relevant. Yeah.
Hi, this is Dr. Atur here. I'm one of the psychiatrists working here with the team. Mm-hmm. Yeah, I think it's point about diagnosing, because I mean, I feel like almost I need to retrain myself, because we always look through a more conversion disorder, dissociative disorder angle with this. So what looks like is we're going into a different narrative of looking through a more disability, you know, neurological lens, which is fine. I think it's quite a good change in terms of our colleagues from neurology and pediatrics coming on board with recognizing this, because as you said, my experience is that it's a lot of the times the way around, that we had to convince our pediatric colleagues or neurology colleagues not to treat with anti-epileptics or you know, medications. It was usually that used to be the case. So in a way, but I suppose, I mean, as you said earlier, I think it's these issues have been recognized and we've been managing it in psychiatry for a long time. Conversion disorder has been well known, and dissociative disorders are well known. They are still part of DSM-5 diagnosis. So in a way, potentially there would be like, there is a potential for conflict or creating a conflict within a patient when they present, and there are two different perspectives on the same thing. So I think I mean, because FND is only the last probably a decade or less than that we kind of pulling out some information and data. So I think it's going to be interesting, because I don't know, because we're good at identifying these patients, where and you still go through the preliminary investigation, ruling out organicity, but generally it's quite clear during the history taking that there's a functional component to that presentation.
Yep. And I'll go through the diagnosis probably next week, but you do need to get a neurologist involved, because you need to make sure there's not another neurological condition there. You need to distinguish between, are these functional seizures, are they epileptic seizures? And the person may have both, so both need to be managed. And there's some medication that people find is helpful. So some medication that might have an anti-seizure effect. I think people talk about Epilin, and they say that's been helpful for them. So it's a mood stabilizer, but it has the anti-seizure effect. And then there's some medication that people say will assist their pain. So all of that needs to be addressed, but they also need to rule out all the other potential causes or factors that are exacerbating their condition. Okay, thank you, that's fine. Yep, so I think we're at time, or nearly at time. So next week, I'll go a bit more into the diagnosis side of it and the management side of it, and sort of look at the role of all the different disciplines working with people with FND and people that you might need to include as part of your team. So I didn't notice anyone say that they were physios or neurologists. So often you'll need to bring in the speech therapist, the dietitian, the physio, the neurologist, and work with them as part of your team to help people. Were there any other questions that people want to bring up? No?
No.
Okay. And if you think about any over the week as well, we can discuss them, anything else that comes up. And I will be providing all the slides as well at the end of this.
Great, thank you.
Awesome.
All righty.
Awesome.
Okay.
We'll see you next week, Kate.
Yep. Okay, thanks.
Thank you.
Bye.
Everyone.
Bye.
Thank you, Kate. Bye.